They hover, and God also hovers and gives us advice on what is the best to do in health. John 3:1 and 12 says, "Beloved, I hope that you prosper in every aspect and in good health, and your soul is prospering. A joyful, wonderful heart is the health of the body, but a depressed spirit dries up the bones." So yes, that's Paul admonishing us that health is important. And we also know that God cares about us because our body is the temple and it functions best when it is healthy. God himself put our body together. In fact, Psalms 193:13 and 14 says, "For we are created in my innermost being." You created my innermost being. "You knit me together in my mother's womb. I praise you because I am fearfully and wonderfully made. Your works are wonderful. I know that full well." So even before the scientists can recognize us as a zygote and two cells that come together to begin, God is doing the knitting. We see these things come together. And what the Bible is telling us is they don't just come together per chance. They don't just come together happenstance. God is in the mix, knitting it together. And so tonight, we're going to have a wonderful presentation about health, but we're going to especially focus on feet. And what I like about it is the Bible also gives feet some significance. The Bible also has some focus on feet, and it mentions it quite a few times, actually. In John 13:14, it says, "Now that I, your Lord and teacher, have washed your feet, you should also wash one another's feet." So feet, very important. And for someone to stoop and wash your feet is a sign of humility. It also says, "Your word is a lamp unto my feet and a light unto my path." So the feet are responsible for taking us places. And if it's taking us places, feet don't have eyes, but the Bible says it's a light unto my feet, meaning that I see the right path to walk in. And God uses feet for so many things. When we look at the Mary Magdalene, she bowed at Jesus' feet, washed it with her hair and tears, and that was a powerful illustration that God used to show us the significance of the feet. Let me talk about prophecy. He has a big statue there with gold and silver and all these precious metals, but the action takes place, the real action takes place at the feet, because feet are important to us. So as we go through this presentation tonight, listen carefully. God loves feet. Feet are very important. And he even went so far as to say in Isaiah 52:7, "How beautiful on the mountain are the feet of those who bring good news." The feet of those who bring good news. So take care of your feet. God loves your feet, and I want you to enjoy this presentation. I will be listening intently to hear myself. Thank you all for listening. I do appreciate this opportunity.
Awesome, awesome. Thank you, Elder Forbes. That was an awesome devotional, and it was very timely, and it reminded us of the text that we are fearfully and wonderfully made. That's one of the texts that I really, really love, especially when I'm talking about the feet, because the amazing structure that God made and how it functions definitely reminds me of how wonderful our feet are. Please give our regards to your wife as she's at home. So tell
She's
her we're
probably
thinking of her
watching.
and praying for her as well. She's watching too?
She's probably watching.
Awesome, awesome. Okay, let us continue. Among diabetics, foot complications are some of the most common, most costly, and most feared. Every 20 seconds, so by the time you count to 20, that's about 20 seconds, a part of a diabetic's leg or foot is amputated somewhere in the world. Here in the Bahamas, we continue to see our numbers increase, and increasing even in younger persons. In 2010, we began a similar seminar called Feet Can Last a Lifetime. That was a face-to-face seminar, but we've converted it to an online seminar now under the name of Feet for Life, which also seeks to increase awareness, education, and skills to help patients, their family members, and caregivers to improve their management of the diabetic foot. We are convinced that working together, we can prevent amputations, save lives, and save limbs. Only then we can realize our mission, which is to help persons living with diabetes to have their feet for life. So as I remember this reminds me of one of my patients who always said to me she wanted to keep her feet for life. I invite you to pause and let us give a moment of silence and recognition of Mrs. Shazara Carey, one of my first patients when I returned home as a podiatrist. From the very beginning, Mrs. Carey came to me and she said she was very concerned about the problem she was having in her feet. And she expressed to me that she did not want to lose her feet. She said she wanted to keep them for life, and she did. She was also a guest on our show for those who are regular attendees a few months ago, and she did an awesome job of presenting her story and also answering some questions. Sadly, she died a few weeks ago, but she definitely had her feet for life. She will be sorely missed, and may her soul rest in peace. Let us observe a moment of silence on her behalf. I will count down 1 minute and we'll just be silent for 1 moment. Thank you so much. All right, thank you so much for your time and recognition of the moment of silence. Let us continue. I am sure you must have heard of the team from Barry University, a team consisting of 24 podiatrists, students, and logistics persons who have been here since Saturday. They came on their spring break to give back to our communities. We have seen hundreds of patients, both privately and publicly. And we also went to Abaco yesterday and was privileged to take care of persons in Sandy Point, Marsh Harbor, and Cooperstown. Well, tonight we have a treat for you. We have a special presentation for you from one of our visiting podiatrists who will actually give us our presentation tonight. We had actually arranged for a patient testimonial, but I don't see the patient here tonight. So we are just going to move on. And if she comes on, then we'll add her at the end. But at this time, we're going to move on to our presentation. Our speaker this evening is the beautiful lady that you see in the top corner. I don't know where she is on your screen, but on my screen, she's in the top left-hand corner. And her name is Dr. Elizabeth Londono. She's originally from Senegal and in Africa, and she completed her Doctor of Podiatric Medicine in 2006. We were actually classmates. That's when we first met at Barry University School of Podiatric Medicine. She completed residency at the Mercy Hospital of Miami Beach, and she is now an associate professor at the Barry University School of Podiatric Medicine in Miami Shores in Florida. She is also in private practice in the Miami area at the North Shore Hospital. You know, and I know that she's highly qualified to speak about our topic tonight. So we're giving her a lot of time so that she can take her time and tell us everything that she knows. And I see that we have a lot of persons who will definitely have questions. So we want to make sure that she has enough time to cover everything. So at this time, I'm going to invite you to help me welcome our speaker, Dr. Elizabeth Londono. You can share your screen and you can begin, Dr. Londono.
All right. Good evening, everybody. Can you hear me well?
Yes, very well.
Yes, we can hear you well.
Wonderful, wonderful. It is such a pleasure for me to be here in the Bahamas with all of you. Thank you for a wonderful few days so far. It's a pleasure also to be before you this evening presenting on such a dire topic. I chose this topic just because, as Dr. Mitchell was talking, she mentioned so many diabetics suffering amputations, and I wanted to today target one of the major causes, one of the main reasons our diabetic patients end up with an amputation, and that is neuropathy. Before starting to discuss the diabetic neuropathy specifically, I just wanted to give an overview of the different types of neuropathy you may encounter. So my presentation this evening will go over defining what neuropathy is, and as I said, the different types of neuropathies you may encounter. We'll specifically talk about diabetic neuropathy, how to diagnose it, how to prevent it, and cures or treatments. What is diabetic neuropathy? This seems to not be the proper presentation. Hold on a second. Let's see. Maybe this one, this is better, I think. Sorry about that. Let's see if that's not the correct one. This is the one. Okay. Just a second, let's see. Something with these presentations. Let's do this again. Let's try this again. Now, here we go. Much better. This one is the one we want. As I said, let's go over what is neuropathy. Basically, the medical definition of neuropathy is the damage.
We're not seeing your screen, Dr. Londono. We're not seeing your screen yet.
All right, hold on. Let me see what's going on here. Why is it not letting me share? Let me try one more time. I think, hold on, I think I know what's going on. I have several screens open. Okay, let's do it again. I had several screens open, so let's try now.
Not yet.
See my screen now?
Not yet. We see that you're sharing, but we don't see the screen.
Right.
It says that you started sharing, but we don't see it.
All right, let me try this way. This way? Anything?
No, not yet.
No.
It's looking as if you have an internet problem.
Oh, that's possible.
Okay, as we begin to, as she's working on the technical side, we can have a few moments, and I just wanted to ask if anybody on the show, on the program tonight, do you have any experience with peripheral neuropathy, or you know somebody who has it? You can just give a thumbs up or open your mic and say if you have it or if you know someone. I know it's a very common condition in our setting, so Okay, I
Dr.
seen the
Mitchell?
thumbs up in the chat. I seen thumbs up. Go ahead, Dr. Horsley. Good evening. How are you, sir?
Fine, thank you. Good night to you and
Good night.
everyone.
Awesome. Good night.
And what a wonderful, wonderful blessing to open, as you always do, with a very positive spiritual word. And that is just awesome. Anyone raising their hand to talk, or are they just acknowledging the peripheral neuropathy?
Yeah, they're in the chat. They're raising their thumbs up, and one
Okay.
person said that they have a client who has it. My mom. So different persons are acknowledging they know persons with the condition.
Okay.
So yeah, so persons are answering in the chat.
I wanted to
So we
ask
know
you.
that it's Go ahead, sir.
Oh, I'm sorry. I wanted to ask you, Dr. Mitchell. I know you use the Remedy and the Remedy Plus, but have you had any success with concomitant therapy like photodynamic light therapy or anodyne or laser? Because there not a lot of people are now using lasers to help promote angiogenesis, or as you know what it is, but for everyone, angiogenesis is formation of new blood cells, new capillaries, allow for healing. So have you ever tried adjunctive therapies with new remedy?
Yes, I have. I've used, I don't have much experience with laser, but I have had some experience with anodyne monochromatic light therapy. So infrared light, I've used that along with the new remedy.
Okay.
And that tends to really improve the neuropathy as well. I also used topicals along with the new remedy. And so I've also used the Neurontin and Lyrica and Cymbalta. I tend not to use them as much now because persons tend to want to do something more natural since it's a chronic problem. And then also I definitely use, before new remedy, I used quite a bit of the over-the-counter B complexes, but now I've switched mostly to the new remedy because of the better results, the bioavailability, and persons tend to have better results within a month time. They can tell me that they're starting to feel better, they're feeling more, and so they feel better. So I've almost exclusively gone to the new remedy now. Once persons can afford to purchase it. If not, then I still will order the over-the-counter B complex.
And now the remedy has a 60 count bottle. So if, kind of like, what do they call that, top up, or getting people like throw $7 a week on their phone, they may not have the full $28 for a month, but boom, every week. So they make a 60 count. So you don't always have to buy 120 pills as far as affordability. And you can still get the benefit of the benfotiamine or the synthetic vitamin B1, which is thiamine. You still get that. And like you said, with the bioavailability, that really kicks in. I don't want to put everyone to sleep, but I probably have something on Neremini or on peripheral neuropathy, if you want me to try to dig it up, depending upon how's doctor coming with her IT connection.
I'm checking with her right now. So I have the presentation. So I'll see if she wants me to just put it up. Once she can log on, I could manage the slides for her. So I'm checking with her right now.
Nice move, Doc. All right. Were you
Okay,
on
Doc.
that? Go ahead.
No, I was going to say you can talk some more because I need to call her on the phone.
Okay.
Okay, I see her. I'll let her back in. All right, go ahead, sir.
Okay, yeah, I was, a lot of everything's online, and I've been catching up on CE online, and I run into you in the chat rooms, getting sharp, getting that information from the top scholars. The one I was on from the No Nonsense, he did not get a recording of all the lectures in advance. And so I think it was one, maybe 1.5 had a little difficulty. And so
No, good evening. I'm back. Monique, see if you can give me, Dr. Mitchell, see if you can give me privilege to share again. Sorry for the technical difficulties, guys. Let's see. Are you able to see the screen now?
Yes,
Oh, finally.
yes, go
All
ahead.
right.
Just slide
Very
share from
well.
the beginning.
Phew.
Slide share
All
from the
right.
beginning.
Okay. So here we go.
Awesome.
Now, starting all over again, as I was saying, when in medicine we talk about neuropathy, first, it has to be peripheral neuropathy. Peripheral because it does not involve the brain nor the spinal cord. So we're discussing nerves that are outside of those structures. And because it's several nerves, the proper term is diabetic peripheral neuropathy. So I just wanted to make sure that that was understood. Now, damage to the neuropathy can be caused by many things, which I will tackle in a few slides. But the proper definition, again, is just damage to the nerves, not including the brain nor the spinal cord. The nerves we are going to discuss carry, yes, motor fibers, but they also carry sensory fibers, which we are very familiar with. But they also have fibers a lot of us miss in our evaluation of our diabetic neuropathic patients. These fibers are proprioceptive fibers and epicretic fibers. These are fibers that basically pick up vibration or positional sense in our bodies. So I'll get very specific in the definition and in helping with grasping the definition of those last two fibers, because we tend to neglect that in treating or discussing diabetes and diabetic neuropathy. So I really wanted to put the emphasis on that in my presentation. So again, I will come back to a slide and discuss that. So I also wanted to make it clear that there may be other causes to neuropathy that are not diabetes. Granted, it's the number one cause, or it is the most common cause we will encounter for neuropathy. However, it is not solely the only thing that causes neuropathy. So certain cancers, multiple myeloma, certain autoimmune diseases will cause neuropathy. Genetic disorders, kidney diseases, liver disease, these work more through enzyme dysfunction, thyroid diseases, certain medications, obviously chemotherapy, radiation therapy, I call them poison really here, but not necessarily poison as we know. Steroids, but steroids is almost like an indirect cause, in that steroids, as we know in medicine, will raise your patient's or family members' blood sugar levels, therefore making them diabetic and indirectly causing neuropathy. So that's important to mention. Statins, this is a very common medication prescribed for high cholesterol. However, one of their or some of their side effects are neuropathy. So it's important to keep that in mind as well. Certain infectious agents will end up leading to nerve destruction. Obviously, the injury to nerves directly, be it from a car accident and your patient has a lumbar injury or has a nerve damage from some kind of acute cause. Vascular deficiency, we tend to also not pick up on the fact that the patient's blood circulation not being well or getting to certain places can't be the cause of neuropathy. So it is important, again, that we come back and discuss that, and we discuss also the effects of smoking on being something that can worsen diabetic neuropathy. So I wanted to make sure at least all these forms of neuropathy or causes of were mentioned tonight. For this precise topic of diabetic neuropathy for this evening, it is important that we be honest in conversation with our patients. I think we tend to pacify them in giving them this diagnosis of pre-diabetic. And the patient's kind of like, well, technically I'm not diabetic. So they end up eating what they want, doing what they want. And then studies actually show that in a few months, they end up being full-blown diabetic. So I happen to be one of those physicians who never uses that term of pre-diabetic. We have numbers that are very precise, very specific in diagnosing the disease or the deformity or whatever we choose to call it. So I'm not sure we prescribe to telling our patients pre-diabetic. If the finger prick or the capillary glucose level is greater than 120 milligrams during several finger pricks, that patient is diabetic. And if the patient's hemoglobin A1C is greater than 5.7 in my books, that patient is also diabetic. Obviously, the most precise way of telling would be your hemoglobin, your patient's hemoglobin A1C, because this takes a red blood cell, calculates the amount of glucose passing by that red blood cell in the last 6 months. What you will see as an attending physician or as a nurse or as a healthcare provider, I should use a general term, your patients will know they're due for testing and eat properly for that whole week. So when you do the test is okay or seemingly okay. However, it's a little bit more difficult for them to do that in a stretch of 6 months. So definitely go for the patient's hemoglobin A1C as being more accurate of a measurement. So how does this diabetic neuropathy come about? The excess sugar, meaning any milligrams above this 120 circulating in the blood, will destroy the microcapillaries on the nerves. The nerves have a fascia, which is this really thin structure. And that fascia is nourished basically by capillaries. And if those capillaries are damaged from the excess sugar circulating, the nerves basically have no nutrition getting to them, no nutrients, micronutrients, and no oxygen getting to them. Therefore, now they don't work as well as they should. So that's really the microbiology of what causes diabetic neuropathy. And then what do we see? What are the clinical signs that you will pick up from the patients? They'll go from telling you, I feel like I'm wearing socks all the time, even when I'm not. I have numbness. It's almost an oxymoron in that they have this numbness and funny feelings and tingly and burning sensation accompanied by pain, because you're like, how are you numb and having pain at the same time? So it's sort of like a funny situation. But that doesn't mean you should neglect their pain just because you're thinking, well, they're neuropathic, so technically they're numb. So that's one thing also I want to address. Now let's get back to the fibers that I brought back before, right? So we talked about the motor fibers, we talked about sensory fibers. Let's pay special attention to proprioception and epicritic. So the motor one is sort of obvious. The diabetic neuropathy, as it becomes more progressive, your patient's muscle waste or they get destroyed by not having enough stimulus from the nerves. That's one thing. That's the motor side. It's obvious. It's easy to pick up on. The sensory side also, as I said before, easy to pick up on because that's really what the patient will complain about. Doc, I have this feeling, I have burning, I have this, I have that. That's the sensory part. The part we don't pick up on so much is this proprioception and epicritic, the imbalance they have. And they start to tell you they fall, they trip for no reason, and you're not understanding why the imbalance, right? They start to want a cane, need a cane or whatever. Part of walking is sensing the ground or having some connection between your body, your feet, and the ground you're walking on. Losing the proprioception and the epicritic is exactly what it's taken away. it's taking away from that balance. So you would see your diabetic neuropathic patient fall more often than other patients, right? So, and again, I'll come and target again how to go about avoiding that and how to go about maybe helping them through that. All right, so how do we go about diagnosing diabetic neuropathy? So obviously the disorder that's there with the patient, you can find out through blood test. That's pretty easy. You could do MRIs and actually study the nerves. You could do nerve function studies from EMG to other electro stimulation to the nerves directly. You could do nerve biopsy or skin biopsy to do the diagnosis for diabetes or the neuropathy caused by diabetes. Also continuing on with how will this present, or what will you see the patients complain about? We covered the sensation, the loss of sensation. This is directly related to the amputations. You will find actually that most of your diabetic patients will be good bleeders, which is what you need for healing a wound. However, because their sensation is no longer present or accurate, they may step on something, cut themselves, and never know. That's really where the problem lies. So the wound is there, the cut is there for days, maybe weeks at a time, and they don't even know the wound is there. That's the problem. Or they can be a piece of rock in the shoe or some kind of other debris in the shoe that you and I, who have proper sensation to our feet, right away would feel in the shoe and be like, wait a minute, let me take this out of my shoe. But that diabetic patient is not going to feel it. This is really where the problem is, because to be honest, if they have the wound and get to you as quickly as possible, the chance of healing the wound is great, as long as you can control their sugar, so on and so on. Where the problem starts is if the wound is there for a long period of time, they don't know about it. And by the time they find out it's infected, bone is exposed, so on and so on. So we make a huge deal about the sensation no longer being there, because that's what leads to chronic wounds and eventual amputations. So I emphasized just now, remembering fibers responsible for balance, so we can minimize falls. The chronic pain is frustrating because the treatment is just maybe not as successful as we wished it to be. So I'll come back to that. The aspect of diabetic neuropathy or diabetes as a chronic disease, truthfully, is that we neglect that this may lead your patients to have depression. So it's a pain they're not able to control. They want to sleep at night, they can't sleep. It renders some of them completely non-functional during the day, to the point where they aren't able to even hold jobs or do certain normal tasks. So this is definitely a problem to target. So how would you target it? What will be management? I am one of those who believes the best treatment to diabetes, diabetic neuropathy, is prevention. To actually never have the disorder, and then you never have to worry about it. So education is always what I say. But if in the event that they come to you and the neuropathy is already there, what can you do to help your patients? The shoes, a lot of people take it for granted, but we talked about that imbalance, those falls, those tripping. If the patient has the proper shoes, especially the custom ones, right? Because you'll have patients with deformities, such as having a cavel's foot or whatever type of foot, and then the deformities don't fit in a proper or a shoe they just pick up at the store. So you may actually need to make them a custom molded shoe that fits the type of foot they have, adding to the stability of them walking, the comfort of them walking, and minimizing even the pain. So another approach that I have is physical therapy. You can strengthen these weakened muscles again. You can increase their range of motion with physical therapy, and you can work also on these patients' stability as well as doing certain treatments to increase circulation to these areas or these nerves that aren't receiving proper blood flow. As I said before, educate, educate, educate. Until now, we have no cure for neuropathy. Nerves receive very little blood supply and just do not regenerate well. They do not heal well. They're similar to the same frustration we have with arthritis, at least osteoarthritis, where there's no replacement to cartilage or anything that heals cartilage or betters heart cartilage. So we just try different things and hope that something works. So again, this is why I emphasize why we shouldn't play with patients with words such as pre-diabetic. Diagnosing them with diabetes as soon as possible and being aggressive in educating them with what foods not to eat so that their blood sugar won't spike, or even on days they have eaten those types of foods, to get out there and exercise a good 30 minutes or so they can burn the sugar. I love sharing with them how if you prick your finger before you go for a 30-minute walk, and after you return for a 30-minute walk, you will see the decrease in your blood sugar without taking any medicine, because exercising pulls the sugar from your blood, puts it in the muscles, basically to run the muscles while you exercise. So it's important to emphasize to them how they should get out there. And it takes nothing more than just a nice brisk walk until they break sweat. They think I'm asking them to run a marathon or I'm asking them to go lift weight or do anything like that. Not really. It just needs to be a nice, fast-paced walk enough to break sweat so that that sugar is moved from the blood into the muscles. So I emphasize exercising. I listed as cause of diabetes the lack of certain vitamins. So you can attempt vitamins, especially B complexes. This also is tagged to one of the causes of diabetic neuropathy or neuropathy in general, which is alcoholism, right? That was one of the causes. Alcoholism leads to certain vitamin deficiencies, and then that leads to neuropathy. So vitamins are important. And then I heard while I was struggling with my my slides, Dr. Mitchell mentioned New Remedy. I also use that in my office for patients to help a little bit with the neuropathy that they experience. She also, I overheard her talking about topical creams. I use a lot of topical creams and patches to help with some of the pain. One of them is capsaicin. It's pepper-based. It kind of confuses the nerves, or at least busy up the nerve, filling the pepper and then kind of forgetting about the neuropathy. So it's kind of like tricking it. I have done lidocaine patches and things like that. Important, however, is to remember that usual painkillers or pain relief medicine do not work well with diabetic neuropathy or work at all, because the receptors on the nerves don't respond to painkillers. So there's a high risk of just ending up making your patients dependent on painkillers. However, the neuropathy will still be there. The medicine we use most, other than the topicals and so on, such as the Lyrica, the gabapentin, pregabalin, are borrowed from antidepressants and anti-seizure family. So, and again, the side effects of dizziness and things that really affect the patient's functionality. So complicating really the management of neuropathy. There are procedures, certain procedures that can be done, such as nerve blocks at certain levels. I went to a dinner not too long ago, and they put an implant actually at the level of the spine, hoping to block the nerves coming to the feet or to the area that's painful, to relieve a little bit some of this discomfort or the issues that the patients get with this diabetic neuropathy. Again, before I leave, I want to go over the importance of diet. I ask the patients very simple questions on first visit when they come, they're diabetic, and some of the signs or some of the things they're telling me is leading me to this diagnosis. They have no idea how to control their blood sugar without medicine. So I actually sit and draw a plate with them, what their plate is supposed to look like. And I emphasize how it's supposed to be many colors, not a boring beige, right? That's all sugar, be it bread, rice, pasta, yams, plantains. Those of us from the island who love to eat those things, potatoes. The closer it is to white or beige, past the mouth, really it turns into sugar. So if we're going to eat carbohydrates, which we should, because 65% of our daily intake food-wise should be carbohydrate, but it just shouldn't be refined carbohydrate. Definitely not added sugar carbohydrate, right? It should be a fiber-rich type of carbohydrates. So I just emphasized also exercising because of how it is able to pick up sugar literally from the blood and put in the muscles to use while you exercise. So blood sugar control is going to be key in not getting diabetic neuropathy. I think we play too much with the numbers. I'm one of those strict ones. I want you as close to 100 as possible. And they're like, Doc, it's impossible. I don't feel well when my blood sugar is too low, so on and so on. I say, that's fine. It makes sense because think about it. Sugar really is a drug and your body gets used to functioning at 300, 400, whatever their normal is. So yes, I do know that when your blood sugar is not at 300, you feel lousy. I know that, but how are we going to target it? We're going to target it by, on a maybe 2-week stretch, we'll go from 300 to like 250, right? So keep it at 250 for about 2-week stretch. And then from 250 to 200 the next 2 weeks. And then, so basically to help the patient titrate it down versus telling them go from 300 to 100 overnight. Of course, they're going to feel lousy because like I said, again, their body is used to functioning at 300. So guide them through this progressive lowering. Science proves it. Every milligram above 120 will destroy nerves and capillaries. So why do we allow our patients to be at 130, 140? Be like, oh, it's not too bad. It's bad. That 30 milligram extra, 20 milligram extra will destroy nerves and will lead to neuropathy. So let's stop playing with the patient. All right. So I wanted to emphasize that these are my references for the presentation tonight. Sorry about the earlier technical difficulties that I encountered. I will take questions now.
Awesome presentation, Dr. Londono.
Thank you.
We're already getting all kind of reports in the chat. So they're enjoying your presentation and was looking forward to it. And so we're getting a lot of kudos in the chat. So thank you so much for that. We have a few questions in the chat, so I will begin with the questions. The presentation I feel was very enlightening and very practical because I love that you emphasized the importance of exercise and diet and controlling that blood sugar. It's so important for patients to realize that, you know, once they control their blood sugar, they can delay or prevent getting diabetic peripheral neuropathy or any other complications of diabetes. And so it's very, very important that you cover that as well. All right. So our first question is, what advice do you have for a patient who have diabetic foot or such severe diabetic neuropathy regarding exercise sooner rather than if they, what do you recommend that they exercise? That's the essence of the question. If they have diabetes and they have severe neuropathy, do you recommend that they exercise until the wound is healed?
Right. So if they currently have a wound, exercising may be difficult because you don't want pressure on that wound and delaying it. So, but still, they can maybe bike, they can maybe row, or they can do upper body forms of exercises. I find that we can always find a way to make that patient be active and not necessarily be on their feet. So you have to be creative in how to encourage the patient to exercise. That's what I
Okay.
mean by they can do upper body things or rowing exercises, but as long as it's not involving standing on their feet.
Mhm. No weight bearing, non-weight bearing
Exactly.
exercises.
Correct.
Yes. Okay, we have another question here. Does having diabetes increase the incidence of tendinitis in the ankles or the feet? Does diabetes, the high blood sugar affect the tendons in the feet?
Absolutely. Absolutely. The same little thin sheet that I mentioned that envelopes the nerves, a similar structure envelopes the tendons. Nerves, tendons, cartilages, ligaments have the lowest blood supply in the body. So any capillaries being destroyed in the nerves, it would be parallel to those same capillaries being destroyed on tendons, therefore causing also that motor part of it that I mentioned in the different types of, in the diabetic neuropathy. We had motor fibers. So absolutely, yes, the patient will have weakness from that.
Okay, so good evening. Thank you for a wonderful presentation. How do you feel about eating red meat with this condition? Does it contribute to the nerve damage?
So the eating red meat part will contribute via having your cholesterol high. Cholesterol would lead to vascular issues. High cholesterol puts plaques on the capillaries and the arteries and causing blood not to get to the nerves, similar to the sugar damage, but high cholesterol will do similar approach and lead to that. So try to go for lean meat, that's white meat we usually call, and then minimize the red meat consumption, absolutely.
Okay, somebody also recommend that they can do chair exercises, and that's good too. That
Right.
persons can do chair exercises. That's a type of a
Yep.
non-weight bearing exercise.
Absolutely.
Yep.
Yep.
That will be good as well.
Mhm.
Another thank you for the presentation. If you are not sure, if I am not sure that I am a diabetic, which is the
Right.
best medical practitioner should I go to be screened? Who is the
Right.
best medical practitioner?
I recommend the endocrinologist because they're the ones who deal with hormones. But to be honest, really, any physician who orders a complete blood panel and orders a hemoglobin A1C with that result should be able to give you a proper diagnosis.
Awesome. So we have a lot of primary care doctors here, and then persons who are also on NHI or National Health Insurance. You can definitely get those blood results or blood tests done, actually covered on NHI. So definitely sign up for NHI and get your blood test, and then you will definitely know your results. I also tell everybody, as Bahamians, we have a higher risk for diabetes simply because of us being, most of us being Black, and because of our obesity, the high obesity level and the low physical activity level. These are all factors that contribute to higher risk of diabetes. So a
Right.
A1C should always be included in your blood panel every year.
Absolutely. Right. I remember one year, Dr. Mitchell and I attended a diabetes seminar.
I could say
And
anybody
the
here in this meeting
gentleman-
probably know that I have
Right.
high risk for diabetes too, because my mom is diabetic, and I have two
Right.
brothers who are diabetic. So 2
Right.
out of 5 children are diabetic. And
Correct.
so I have been working for years to continue to prevent getting the diabetes. My mom has multiple complications from diabetes. And
Mhm.
so I've been working hard to prevent that. My A1C actually, I think last year was 5.7. I just did it, I think maybe last month, and it's down to
Right.
5.3. And
Good.
so that was awesome
Good.
because I implemented a program last year where I got strict on my eating plan. I lost some weight and my exercise. This week has been a little crazy, but next week I'll be back on track. And so
Yeah.
between implementing all 3 of those areas, I saw the results. And that was a good
Right.
result. I called my friend Marlene and told her, and she was very, very happy. So so it can be done. It can be done. And so we must work
Right.
towards that. And so even though I'm not diabetic, I monitor my A1C every year when I do my labs. And I check it to see if I'm going up or I'm going down. And I definitely want to go in the down direction. So
Right.
everyone can ask to have that test done. There's no, as a matter of fact, you can go to the lab and have it
Correct.
done or by yourself. And I think it's about
Mhm.
$40. So yeah.
Wonderful.
So waiting for the rest, thoroughly enjoyed your presentation. Thank you. Next question. I am having tingling and ants crawling between my right knee and thighs. Is this a sign of neuropathy as well?
Yes, diabetic neuropathy or neuropathy can even be in your hands. So there's no discrimination there, just knee and below or the lower limb. I mentioned one of the treatments being a placement of a stent or a stimulator at the spine. They go as high up as thoracic level 10, right? So that's all the way high up your back. Definitely, it can be your thigh. To be specific, just get it checked, have some tests run, from blood work to maybe nerve stimulation tests and things like that, but absolutely can be neuropathy.
Okay, so I would also like to say that a classic sign of the neuropathy is that it starts in a stocking and glove presentation, meaning it begins at the tips of the toes or the tips of the fingers and it moves up. So it can move up the feet, up the leg, ankle, leg, calf, thigh. So it can move up the legs. And so that's classic for the neuropathy as well. Our next question says, can you put the medicine she recommended? Okay, so we can for the nerve in the chat. Okay, we'll put the new remedy. Dr. Horsley, you can put that in the chat for us, please. In the chat she wants to know the new remedy that was recommended. You can put that in the chat, and then also we'll put the capsation in the chat as well. So persons
Correct.
could also purchase that as well. That's the topical medication.
Right.
Excellent presentation. I have had severe diabetic neuropathy for 7 to 8 years. I am on Sirolude and Lyrica and want to get off these medications. I want to get off these medications gradually. What can I do?
So I would recommend controlling your blood sugar. Again, go by it progressively. Don't just have a goal for overnight, but controlling your blood sugar is dire. It's like the number one thing, high top on the list. Picking up exercising so that the blood can get to these tissues that hurt. Not even having diabetes or neuropathy, if your circulation is not good and oxygen is not getting to the tissues of your feet, you will have pain. So it is extremely important to go exercise. Whatever it is you enjoy, it can be you put music on for an hour in the house and you dance till you sweat. I'm not picky, just do the exercise. The unfortunate thing that maybe I didn't emphasize so much in my meeting, in the presentation, once the neuropathy has set and the damage is there is no reversing it. So the amount of nerves already damaged, that's that. You may be able to prevent further damage, but really so far we don't have a reversal for that neuropathy. You can improve, like I said, tissue perfusion by exercising more. Maybe have your primary care physician put you like on some sort of blood thinner if you don't have any allergies for that. Maybe certain massages or stimulation devices, machines like electrostim, or maybe those foot massage compressions and things of that nature to help. But really what's going to be so super important is monitoring your diabetes and making sure your blood sugar is well controlled.
Okay, awesome. So we have another question here. How often should this person ask, how often should they have their feet checked? I'll answer that one. So as a diabetic, you should come in and get your foot checked. You can go to any of our offices get the foot check. And once you get your foot check, we will stratify you into what risk category you're in. And then based on that risk level, we will plan for when we will do your rechecks. So it may be a month or it may be weeks according to what we find. So if you have an ulcer, active ulcer, it may be a couple of days. If you have deformities and stuff like that, it may be weeks. If you have good sensation, no deformity, good blood flow, then it may be a year before we see you again. But it's based on how well you do when we do your checks. And so we will do that again. Now, next question. What does being Black have to do with having a higher risk of diabetes?
Absolutely. I'll answer this one because, like I said, we had a very specific presentation on this. Just being of African descent, we have genes that are very different from other populations. It's called frugal genes. I'm not sure, Dr. Mitchell, if you remember that beautiful presentation we saw back then. The way our genes processes food is so efficient compared to other races that we shouldn't eat as much as other races. That's one thing. And we shouldn't eat the type of foods other races eat. But I'm from Africa, which having spent now 5 days here in the Bahamas, I see that we are almost identical. And status in my country, you show it by being thicker. By having eaten so well, you can show off the things you eat, which may have not been traditionally what happened in Africa. We probably ate grains that were maybe millets, that were maybe quinoa or fonio, things like that, and not refined white rice. Or we're eating potatoes that are not the color yam that we should eat. So we're eating a European diet that doesn't belong to us. But we think that's what status is about. And it changes completely our genes. That's the one thing. But the other genetic thing, as Dr. Mitchell is talking about, if your mother's diabetic, 2 of your siblings are diabetic, you definitely have the genes for diabetes. Guys, before being diabetic in the US now, there's a marker for diabetes that's called HLA. That can be precisely pinpoint to your likelihood of having diabetes. So we're picking up diabetes and completely now wanting to shift it to a new category as an autoimmune disease, meaning inheritable. It's proven by a mother having gestational diabetes, and then that baby dealing with the insulin insensitivity during pregnancy, being more likely to be diabetic as an adult. So your genes are 100% almost predictive of what you're going to have. But we list diabetes as a modifiable. In your lifestyle will definitely determine if you're going to end up with it or not, although you have the genes for it. I hope that helped.
Yes, it did, definitely. What food would you, what type of foods would you recommend that persons eat who wants to prevent the neuropathy or prevent the food? What meal should be the biggest meal of the day?
Right. So I always say, and again, this is a proverb I borrowed from the Hispanic language. And they say, you should eat breakfast like a king, right? Lunch like a prince, and dinner like a peasant. That's what they say. You don't want to go to sleep your belly full, because you are doing nothing while your belly is full, and that's sugar. So your breakfast technically is your source of energy to carry you throughout the day. So you eat a nice, healthy carbohydrate. It can be your oatmeal, whole grain based. I'm not talking about the package added sugar one that you buy from the store. I'm talking the natural oats that you're going to cook.
Old fashioned.
Exactly. That and a nice protein. It can be a lean sausage, it can be a lean turkey, a lean whatever, but a good source of protein, or even it can be a hard-boiled egg, something like that. Sugar, your sugar as a diabetic, I don't even recommend sugar substitute. Natural fruits for breakfast. You leave here, there's natural fruit. You are allowed to have that at breakfast, but not later on. I'm not saying have a big mango at 9 p.m. and then by 9:30 you are sleeping. No. So try again. Breakfast, a nice big one to carry you throughout, but again, it should be healthy grains with a side of really good protein and lots of water. Water, 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 water.
I would also like to recommend nuts as a protein option, as a protein source. Persons
Yep.
can also put that to there. That's what I do with my oats, nuts and fruits, raisins even
Mhm.
sometimes, but fruit, fresh fruit and nuts in my oats. And so that makes a really, really, really good breakfast as well. Good night. This is an awesome presentation. I'm learning a lot and great knowledge. Thank you. So we have here New Remedy Plus, and Dr. Horsley has put inside there where the pharmacies where persons can get the New Remedy from. So we have great presentation. Thanks so much for the webinar, all the information. So good evening. I'm private, would appreciate guidance if possible. I'm afraid I have stopped checking my levels regularly, but what I do, when I do, it's under 100. I was diagnosed as pre-diabetes a year before last. Sometimes I would itch in the palms and the soles of my feet. What was doing well with the Diabetic Research Institute, but since they closed, I have no one to be accountable to. My right big toe has been trying to grow back for 2 years. It's 80% the toenail, I guess. I love my feet and want to continue wearing lovely sandals. I need help on what to eat and to prevent diabetes. So it sounds like we need to do another session on the food. So definitely a very informative session. Awesome. Thank you so much. We have a couple of persons who also raised their hands, so we can recognize them. Margaret Forbes, my good friend, Margaret, go ahead and open your mic and ask your question, please.
Good night, everyone.
Good evening.
I didn't really have, at least I'm tuning and I'm really enjoying this and getting a lot of knowledge. Yes, Dr. Mitchell, my friend, classmate, I'm really, really enjoying this tonight.
Good.
Yes, one question I wanted to ask, at one point in time, at least every now and then, so often I notice it, I just have this numbness in my leg when I'm standing up.
It's one leg, both legs?
It's
Where?
just one leg, like in the calf area.
Right.
From the calf go down, but it doesn't down. But once I'm sitting down, it'll stay like for about 15, 20 minutes. After it goes away.
Right.
If I'm like it, yes.
Right. So one of the things that I do for a differential diagnosis, meaning something else that it can be besides diabetic neuropathy, is to make sure you don't have low back issues.
Okay.
If you have sciatica issues, it can present as a calf pain like that, similar to what. So if you've had like lower back injury before, or some kind of like lower back surgery or something like that, it can definitely present that way. Okay. This is a topic most of my patients don't want me to discuss, but when they have a protruding stomach, right, it disturbs the spinal position because it takes your center of gravity now and pushes it forward, which pinches your sciatic nerve. So without having lower back issue, if you have a heavy weighted belly that's pulling your spine forward, your sciatic nerve can be pinched from that, because it's the sciatic nerve that goes from the hip area, it comes to the back of your thigh, it comes to the calf, and goes even to pinky toe and the toe next to it. Your sciatic pinching will do that.
Okay.
So that's what I would make sure, that you don't have a back issue that's actually leading to this.
At one point in time, I was having a little back issue. I therapy with it. And then now I think it was also the chair that I sitting at my office.
Yeah.
Yes, but I changed the chair, and then now I also have a pad that I use in the chair. It has
Good.
helped me a lot now
Good.
because say the pain, the numbness, it was terrible, but it has eased a bit.
Yeah, you could have been also pinching it at the level of behind the knee. If you were sitting and you were compressing the leg by how you were sitting, there's a
Right.
piece of the sciatic nerve like right behind the knee that you could have been pressing on too hard because of how you were sitting and causing that, we call it neuralgia, like a temporary neuralgia type thing.
Okay.
Mm-hmm.
Awesome. So
Thank you.
Ms. Forbes, you can put your hand down for us, please. Before we finish, I want to ask Dr. Horsley to give us a little bit more about the new remedy and exactly where persons can find it, because that's a product that a lot of persons are asking about in our chat, and persons would like to be able to have access to it. So Dr. Horsley, you can give us some word on that, please.
Sure, but I'm not talking to Dr. Londono because I went to South Beach Clinic today to say hello to her and all of the visitors from Barry, and no one was there but patients. So guess who had to work after work? So she's on my list, and I'm glad I wasn't going to miss this Zoom for the world. Just to let her
Awesome.
know.
Good.
And also,
It's a pleasure to meet you.
Come tomorrow. Come tomorrow. We'll be there. We'll at Fleming Street at 1 and South Beach Clinic at 1 as well. So come by and meet them.
And I'll bring my goggles for clipping them nails. Those nails were thicker than their toes. So I'll make sure I bring my goggles and join in with everyone. Dr. Mitchell, what is wrong with you and what is wrong with the gentleman I met today? The only two people in the world who chose diet modification, lifestyle medicine to reverse their type 2 diabetes. What's your problem? Why don't you just keep diabetes like everybody else, take your medicine, get your neuropathies, and get it over with?
Nope.
So can more people join you and the gentleman today and actually reverse type 2 diabetes? Is it possible, or is that a myth?
It is. No, it's
Yes.
possible.
It's very
Definitely
possible.
possible.
Okay,
We have
okay.
plenty of studies in the US that shows reversal of diabetes, even the type 1, believe it or not. And this is directly the reason why now certain health insurances in the US approve bariatric surgery, right? Like a direct link in weight loss and going from being insulin dependent to non-insulin dependent, continue the weight loss and be non-diabetic at all. So it is absolutely very much so possible with diet control, again, weight loss and exercising, absolutely.
Good, good, good. Well, I like that idea about having a Zoom on food, alternative sources for protein other than them little sausages. They could have little vegan sausages.
Yes.
Because, and I think that when people eat meat, they should eat farm fresh, what is it called? Cage-free or grass-fed meat.
Right.
Go to Long Island, Bahamas, you get the fresh mutton, fresh kill, fresh kill. Go up to Ferguson Road off Bay Street and grab one of them chickens, fresh. Don't eat that Chinese chicken. That chicken comes from China, right? You know what came from China in 2019. Why are we eating the chicken and stays frozen for 6 months? I don't care how crispy it is. We need fresh protein. And I'm a vegan, but I also advocate that my patients eat fresh meat, fresh kill, not meat with steroids, hormone. A lot of things that Dr. Londono mentioned are in the meat, the hormones, the steroids, the causes of polyneuropathy. So if we eat meats without those chemicals, like you said about the cholesterol, things that cause polyneuropathy, if we can stop eating more fresh meats, will also help control that. And so do many of your patients try to reverse type 2 diabetes, Dr. Londono?
So, like I said, like my diabetic patients on first day, I sit and I go over what their plate is supposed to look like, what I would ideally like them to do in a week, spending time, like 3 days out of the week, I need you to give me 30 minutes walk.
Okay.
I educate them on the importance of shoe wear, not walking barefoot, having a regular visit and things like that. I would say about 60% of them are responsive to that first visit talk, and I'm able to get excellent results.
Wow.
But if you noticed, a part of my presentation touched on depression or the psychology of chronic disease, to be honest. So that makes certain patients kind of like very difficult for them to come out of that dark that they put themselves like, oh, this is going to be for life anyway. I'm still going to drink my 10 cans of Coca-Cola or whatever. So sometimes if it's really obvious that the patient needs help, I'll do a psych consult, help them through that stage, because maybe all it takes is just a mild antidepressant and you see a huge change in the patient. And I know that my next colleagues will talk about this multidisciplinary approach in their presentation in a few days. So please check them out. So that's what I try to do. I'm in touch with the primary care physician. I recommend the endocrinologist, whether their sugar is controlled or not, because I like the input from other people. I right away do a vascular evaluation. So I have like a baseline and I'm able to pick up deterioration. So I must say that those that I catch, I call infancy stage of the disease, and they are responsive to the plan we work on together, I do get pretty good results with them.
Okay. Dr. Mitchell, both doctors, I wanted to mention that one of the most frequent misdiagnoses in medicine, in my opinion, is the DVT. And I was reading the comments, the leg cramping, leg burning, and your answers were spot on. But I was also kept thinking, people need to check out, especially, I've seen an increase in DVTs or deep venous thrombosis since everybody started taking that jab.
Right.
And I haven't seen that many in 45 years of practice.
Right.
And all of a sudden, every week somebody got a DVT.
Yes,
So
I agree.
That might also be contributing to some of the cramping, the burning, the tingling, in addition to polyneuropathies, which you gave an extra list. So I'm gonna throw DVT on there and encourage patients that you don't have to have the classic swollen leg, can't hopping around. Sometimes DVTs are very tricky, and they should always try to get that knocked down.
It's one of my nightmares, so I always screen for it because it will kill your patient faster than neuropathy. So I really do not play with DVT. So I'm really quick to be like, go to the ER just because it's only one leg. We're going to play it safe. Let's rule DVT out. And then once I know it's not DVT, then we can tackle or try to tackle the rest.
Excellent.
But absolutely, unilateral pain or anything funny, really unilateral, especially if the patient fits the criteria of maybe being a younger one on birth control, smoker, overweight or whatever, for sure the red flags go up. Tagging along with this increase of DVT or clotting disorder, linking it to COVID-19 is definitely something not fabricated, not necessarily the jab part, but COVID-19, instead of just being a regular virus, we know that it was an endothelial lining disease or virus. So it actually directly attached to the vasculature and caused an increase in gangrenes. I had gangrenous toes from COVID. I only found out because, like you said, there was an increase, and I was like, all of a sudden, why am I 30-something-year-old, perfectly healthy, having gangrenous toes and these weird vasculitis I couldn't diagnose? So I biopsied one of them, and it ended up that it was COVID. So absolutely, yes.
Wow.
This was good timing because we have a question in the chat now. Somebody is saying, What about cramping in the leg while sleeping, like stiffness, and it's very painful? So this
Right.
person needs to probably contact us and have that checked to make sure it's
Yes.
not a DVT, and so we
Correct.
can move from there.
Right. So definitely recommend that you see a doctor about it. That rest pain, however, in medicine, we tend to always say is vascular, but to be on the safe side, just because we're talking about the DVT and all these things, get it checked to be safe. But usually rest pain tends to point towards definitely some vascular compromise.
Well, that's interesting. So as far as the remedy goes, it's available in a lot of pharmacies in town. We're getting it into Freeport for sure. And pick up your remedy. Get that benfotiamine, which is a synthetic vitamin B1, which has better bioavailability. But I could hear in your lecture the things that I think about, because you hit on the medication like Neremini. You also discuss therapeutic shoes, which are super duper duper important, and diet, lifestyle medicine, or lifestyle change. I think those three alone are game changers, and especially
Right.
for what we're calling the pre-diabetic, which I agree with you. What is that's like being pre-pregnant
Exactly.
or pre-venereal disease.
Exactly.
There's no pre, okay?
Right.
You got it or you ain't got it.
Exactly. Thank you for that. Thank you for that.
We have
Yeah.
another comment in the chat that says from Moulton Keen, and he says, or she, diet modification definitely works. One of my OBGYN professors always said he places all his patients on a FFFVNOBC diet, and that
Right.
stands for fresh or frozen fruits and vegetables, nothing out of a can, nothing out of a bottle or a can. So that's a natural diet.
That's
So
right.
food as God made it. So
Right.
that's, I agree with that 100%.
Absolutely. Right.
Yes.
So
Nice.
one of the other classes that I teach at the university is immunology. And in studying the rise in autoimmune diseases, it's
Right.
brought up that the fact that we lived in farms and actually interacted with animals and interacted with our foods by touching it. Like you actually touched it, or your bare feet touched the ground, gave us different minerals and vitamins that many people now in the city, you just go to the store and pick up an already canned thing or packaged thing, and that's what you cook. You're not interacting with your food, smelling it, touching it, all those things. There's specific hormones and things that it stimulates in you to interact with your food that we don't do anymore. So,
Correct.
yeah.
Yep. That's why there's no more
Awesome.
vitamin B around in our foods.
Right.
All the bleached water, chlorinated, fluorinated, kills all the bacteria when it makes the natural vitamin B. We didn't have to worry about when I was growing up.
Right.
Now it's no vitamin B around. It's gone. So
Yes.
that's good that we're
Right.
discussing that.
We'd like to recognize those persons who are on the chat with us tonight. We have persons from Freeport, from Bimini, and I see a Lucas from Canada, and I'm wondering if that's Dr. Lucas from Canada. So we want to say hello to all of them.
Right.
Of course, we have tons of people from New Providence, and we just want to say welcome everyone who attended the meeting. Tonight we're getting ready to close, so if you have any questions, you can do that now, or you can always get in touch with us and let us know. The phone number here is 605-3668. I'm gonna put it in the chat because I think I forgot that last time. So I'm gonna put the phone number in the chat. And so if you need to call us for any questions, or you have any additional questions that we didn't answer, you can always give us a call, and we'll be happy to do that.
Great. Great.
Good night, Dr. Mitchell, all the way from
Good night.
Rumpke, I'm calling.
Oh
The
my
presentation
goodness,
was
you promised
good.
and you showed up.
Yes, yes, I did. All the way from Rumpke.
Now,
And you know what I have to say? I say
Go
the
ahead.
government should at least assist with trying to bring healthy foods. Try to incorporate farmers, you know what I mean?
Right.
And then the food don't have to be so expensive, because a lot of people want to eat healthy, but they can't afford it because you go to the shop for just cane, sugar cane, that expensive. They going like $5 and $7. You go for a hand banana, that's another price again. Dilly, I pay $2 for dilly. Dilly, now you think one dilly should cost $2? So that's what I said. The government need to put their hand in to assist, because that's why the people can't afford to eat. Like she said, you can't feel your food. Like how I am here eating some tamarind and I was eating some juju and all these things. You ain't have access to some of these things like that. So the government need to assist. Because as long as I was working with the CNC program, I said the government is solely responsible for their people. So the government needs to assist. So that's my little 5 cents. I think the government needs to step up to the plate.
Awesome. We appreciate that. We definitely appreciate that all the way from Rumkey. So
Yeah.
thank you very, very much.
You're welcome.
Okay, so we're going to get ready. Go ahead.
So just right quick, the government only assisting this government and all governments do. They assist you in the amputation. That's free. But everything else costs. And
That's
they
the
say,
truth, Doc.
yeah, and free costs too much. That's why free costs too much. So just real talk, and you just continue to take care of yourself and keep tuning in with us, because this is very informative and always appreciate the talks. Thanks, Dr. Mitchell.
Yes, will
No
do.
problem. We have another comment here that says backyard farming is important. So we definitely want to do that. And then we have another question. Who is that from SVG? I don't see that one. St. Vincent and the Grenadines. I'm sorry, did I not recognize them? St. Vincent and the Grenadine is also on the call tonight. So very good. Nice to have you. Let me just take a look, make sure I didn't miss anybody else. So awesome. Thank you all so much for coming. We really appreciate you stopping by and making sure. We do have a YouTube channel called Feet for Life, just like the name of the meeting, FEET, for the letter 4, Life, LIFE. Once you go on YouTube, you look for that channel and you can go to that channel and watch all of the previous videos. So if you want, you can also send me your email or your cell phone number so I can send you the link as well. But you can go to that channel and subscribe to the channel. Once you subscribe, you will have access to all of the videos. So we encourage you to do that. Thank you for attending the meeting. And we invite you to go to the channel, make sure you watch it. And then we are happy that you were here. Our next meeting is the 13th of April, and we'll be here. We meet monthly on the second Thursday of the month, and we usually have an exciting topic. If you are interested in any particular topic, like we did have a lot of questions about food tonight, so we may do something about food. We try to be topical based on what is going on around that time. And so, but if you have any particular questions or any particular interest, you can definitely send that to us and we can see how we can accommodate you. But our next meeting is on the 13th at 7:30 p.m. right here. We're going to now ask Elder Forbes to give us our closing prayer, and then we'll be done.
All right, let's bow our heads. Father in heaven, Lord, we thank you for the enlightenment that we've received tonight. We've learned a lot, and we ask, oh God, that we would not only learn, but we put into action these things that we have learned. And help us, Lord, those who are already in the throes of these dreaded diseases, help us to take the steps that we've learned to prevent them, or I should say to cure them. But, oh Father, for those of us who are not involved, help us to be diligent and vigilant in our eating and the things we do to ensure that we do not get them. We thank you for the presentations. We thank you for the presenters and all the questions, all of which gave us more enlightenment as people asked and made comments. And so we thank persons who also put together the program. We ask you to bless their efforts, and may it be fruitful as we gain healthier and healthier knowledge to a healthy and prosperous life. Thank you, O Lord, for this opportunity and for everyone who attended. In Jesus' name I pray. Amen.
Amen, amen, amen. Thank you all for attending, and we hope you have a wonderful night. I see persons are putting their emails in the chat, so if you want to, definitely you can put your email. We can get in touch with you. We have Dr. Londono. We have many thanks here. Kudos in the chat saying thank you for a wonderful presentation. Thanks very much. And so thank you very much, Dr. Londono. We know that you're missing a wonderful dinner tonight, but we're happy that you are willing to give that up and to be with us tonight. Dr. Horsley, we also want to say thank you to you for always being willing and ready to speak up whenever we need you to. And I appreciate you for that. We ask that all persons, if you want, you can put your email in the chat or your cell phone, and then we'll be able to send you the link. But good night, everyone. Have a wonderful evening. Our next meeting is on the 13th of April, and we will be right here in Zoom land, and we will send out the link, and we hope that you will join us. Thank you so much.
Good night. Good night.
Good night. Good night. I see a raised hand. I don't know. Miss Denise, you had a question?
Good night, all.
Good night.
Good night,
Good
everyone.
night. Excellent presentation, Dr. Londo, and thank you, Dr. Mitchell, for your efforts.
You are welcome. Thank you so much as well for coming.
Excellent presentation. Excellent.
Awesome. We appreciate your
concur.
attendance.
I concur.
Thank you. We appreciate you.
This was recorded. Where can you get the recording of it?
There are two ways you can get the recording. You can go to our YouTube channel, which is Feed for Life. Just go to YouTube and search for it. I'm actually going to change it to 242. I mean, Feed for Life 242. So you know the one from the Bahamas. You can go and watch it there, or you can send us your email or phone number, and we'll send you a link to that actual site. In the chat, you can put your email in there, and we'll send you a link to the site.
Okay. Thank you.
You're welcome.
You can't get off the link.
Yeah, just log off. Just leave the meeting. You can just leave the meeting. Hey, Nurse Williams. Oh, that's Stephen Williams. Oh, I thought that's Stephanie. You have someone from Exuma as well?
Dr. Mitchell, when are you coming to Freeport again?
I'm actually there next Thursday on the 16th.
Oh, okay, thanks. Need to see her.
How are you doing?
I'm good, I'm good.
Awesome, awesome. Oh, that's you. Oh, I could see both of you. Now I can see you, yes.
Yes.
Ask Dr. What his name is? Horsley.
Horsley.
What do you know about that Long Island man? I only smiled when he said that.
He just went to Long Island, I think in February or something, either this year or last year. And from the time he went to Long Island, he's been talking about Long Island like a pro.
He make my heart glad when he talk about that Long Island man.
Yeah,
I'm trying to get some of them preachers here in Grand Bahama.
Uh-huh.
I won't get
He
them
speaks about Long Island like he's from there.
Hey!
right, it was a good presentation.
Wonderful.
Awesome. Thank you so much. Thank you so much for attending.
Okay, we'll see you. I'll see you next week then.
Awesome. Awesome. Thank you. Good night.
Good night.
Good night.